good. So I'm having the pleasure to present my also CVPR paper, LesionLocator, which is basically about zero-shot universal tumor segmentation and also tracking in 3D images, so in 3D whole body imaging, mostly CT, but also could be MRI images. And I guess from the title, you already saw that this is about tumor segmentation, but also tracking in medical images. But before we really like delve into the topic and look at it closer, I want to take a step back and remind everybody basically of the foundation of this paper and also many other medical work, which is the Meta's SAM model. I guess probably everybody has heard about this. It is a segmentation model where you are able to place prompts, or so in this case could be points or boxes in an image. And as you can see in this animation, you get the segmentation mask of that very object. And after Meta released this, of course, the medical field didn't take long, and there were medical adaptations. For example, the most prominent one and the first one was Segment Anything in Medical Images by Yun Ma here. But there were many others, and by many others, I actually mean a plethora of others who literally adapted the Segment Anything idea or model in many different ways for the medical field. And these are high-ranking conference papers or journal papers. So we have Zagwall here, which I think a NeurIPS highlight, and Scribble Prompt ECCV, Vista, also CVPR, Prism, which is a MICAI oral. So many different high-ranking papers, which are all interesting and all have their very own touch to the promptable segmentation problem in medical images. So that's why we thought, well, if there's so much research and so much focus being put into this topic, then the problem is solved, right? So you should now be able to click on a structure of interest, click on a segmentation mask or a structure and get the segmentation mask out, right? And in our case, what interests us was lesions, right? So we wanted to be able to click on the tumor, click on the lesions, because those are the pathological interesting objects in medical image segmentation, and be able to get the segmentation mask. So we tried the models, right? We tried, for example, in this case, Vista 3D, so the NVIDIA tool, in a zero-shot setting, and this was the result. I mean, as you can see here, this is unfortunately not what we hoped for. And this is, again, in their online tool on their images, so it's not even an image we uploaded. And if you click on the tumor, which is kind of even well visible here on the left side, you see that you have some patch overflow here, and you might say the right boundary is right, but the rest of the liver is then segmented, and it's kind of a weird segmentation mask, right? You could correct this with negative clicks, but this is initially, of course, not what we want. And going further into this, we also identified more research gaps, so to say. And one of the big research gaps is basically that most of the models like this. You have a ground truth object, which could be a lesion here, and the SAM model basically in the end gives you a segmentation mask, which has these sliced artifacts. So you end up with a segmentation mask which looks very jagged, and on the right side, this is really like escalating a lot, right? So what we ended up doing is we didn't look at this only qualitatively, but also quantitatively, and wrote a paper about it. So big shout out to my colleagues Konstantin and Tassilo, who put a lot of work into this. And we basically compared a whole lot of models, so all the models you saw earlier and other models as well, on the task of promptable medical image segmentation with different ways of prompting, and you differently sliced images and all of this. And there's a lot of insights in there, but the TLDR is basically that the SAM2 model is already able to really outperform many different 2D and 3D models. And also, none of the models really were super convincing. So there's no model out there which is super nicely working on all structures, especially lesions are a very hard structure. And now I already alluded to the SAM2 model, which is not only better, quote unquote, on some targets, but also offers another previously unseen capability. And that capability is tracking. So the SAM2 model first introduced the capability to click on an object in a frame of video, and you follow that frame throughout the video, you follow that object throughout the video, and in each frame, you get the segmentation mask over time. And this has not really been taken to the medical image domain. But then again, we thought patients visit the doctor also several times. So we also have time series in the medical image domain where you want to do tracking. And there are approaches definitely for like surgical videos in the normal 2D plus time frame. But there weren't approaches in the 3D domain where you have CT scans, MRIs, and all of that stuff with various different examination time points. And this is exactly where the paper I want to talk about today comes in, where LesionLocator shines basically, where we want to unify segmentation and tracking. So let me quickly give you an introduction into the task itself, which is also a quite relevant clinical problem. So what you would want to do is be able to click on a tumor, click on the lesion, and have that click trigger a segmentation in the 3D image, but also have it retrieve the lesions in follow-up scans, as you can see here, right? So basically, you want to be able to place a prompt, let's say it's a 3D bounding box or a click, and you get the segmentation mask, but also the segmentation mask of all follow-up scans. And desirably, you would want to see then a graph like this, basically, where the lesions over time shrink, so the treatment is working, hopefully. But again, from this image, you can immediately see that there's some issues, especially in comparison to the normal video tracking models. The time frames in between the scans are not split seconds, they are actually months usually. And then the examination looks completely different. So for example, in the first image here, you have an arm, which is then not present in the second image. And in the third image, you suddenly have a whole different field of view. So suddenly the shoulders appear here, right? Which were not visible in the previous scans. And these all make up difficulties you have to deal with when dealing with this task, when trying to solve this task. In clinical practice, what you usually would do, that's why I said it's kind of an important clinical problem as well, is you have the so-called RECIST criterion, which basically gives you a diameter. You would only draw around 5 target lesions and maximum 2 lesions per organ. And then with this diameter, you would judge how the patient has evolved over time. But you would completely neglect other lesions in an organ, but you would also not do a volumetric analysis. So you would not do a segmentation because that's just too time consuming. And as you can see here, you might just not cover the full picture with just the diameter, right? So the hope is that a segmentation mask gives you more information, and you can also draw more information in terms of, let's say, radiomics or something about the lesion in that sense. And as I already alluded to, if you have an organ which is covered with lesions, covered with tumors, you would only pick 2 lesions, follow those lesions throughout the treatment to determine if, let's say, chemotherapy is what you're sticking with or if you're switching treatment. Even if other lesions around the previously determined target lesions appear, or if other lesions really like grow and explode. And on the other hand, what we would want to provide is an image on like you see on the right side, where you really have segmentation masks for all lesions instead of just the diameters, and you should only be able to click on the lesions and then retrieve them and see the evolvement over time. So now that I've talked a lot about the clinical practice and the setting of the whole paper, let's quickly brush up on some difficulties here and then move over to the final architecture. Because the difficulty is definitely that we have lesions all over the body, which come in all shapes and sizes, and you have many tumors in one area, and they might vanish, disappear, reappear, merge, you name it. And to kind of tackle that problem, we try to go the round of the promptable segmentation, so the human in the loop, which then defines the structure of interest. So, as promised, this is the segmentation architecture. We're not going to look at tracking just yet. So first, let's prioritize the segmentation. And the idea here is that similarly to the SAM1 model, you would want to be able to have your medical image passed through the network, but also have your prompt. And in this case, we're working with point prompts and box prompts. And as you already see here, what this relies on is basically an underlying encoder-decoder structure. But the big difference to many other models and also many other models in the 2D domain is that the prompt is encoded in the first iteration, basically. So we call this early prompting, whereas in the SAM architecture, you would just encode the image and then do late prompting in latent space. And to be frankly honest, I would say that technically late prompting in latent space is probably the way to go. But just for the medical domain, where we do not have enough data, where UNets are still most of the times the state of the art. If you look at all the like segmentation challenges in 3D medical imaging, we also chose to go the route of a UNet. And in this case, what we did then is we had a medical image, so it's 3D volume, and also an associated channel, which we just append to the medical image. And in that channel, we place the prompt. So in this case, the structure is super simple. It is just a UNet, so to say. And also, this UNet gets a segmentation mask or a point prompt or a box prompt in the first iteration here. So basically in this prompt channel, and then the medical image as well. And the big advantage here is that from the get-go, you already have the rough location of the prompt encoded in the volume because you prompt at the same spot, so to say, as the lesion is in the medical image. And this, if you look at the data set now, has to be trained with a whole lot of images to really get it working. Even though we're doing early prompting, we still need lots of data to really make this work out of distribution. And we even do a slight trick here, so to say. We first train the model not only on lesions, but we train it on everything we could find. So on organ datasets, lesion datasets, and basically any different target structure in CT, MR, and PET images, you name it. I think we trained in the end like 50 different datasets we scraped from the internet to have a very robust pre-training setting. And then we fine-tuned only on lesion-specific data. And for the lesion data, I'm showing these pie plots here, basically, where you can see the different lesion types. So we have lung lesions, whole body lesions, liver, kidney, all sourced from public datasets and then thrown together in one big dataset. And then I also did this small analysis here where you see the lesion size, and we have various different lesion sizes, very different settings of lesions to make it really, really robust for new lesions appearing. So speaking of new lesions, this is the actual results we show in the paper. And we benchmark our model and all the other models on 6 completely held out different lesion datasets. So these are, again, publicly available datasets for lesion segmentation, except for the whole body melanoma one, which was annotated at the DKFZ, so our center here. But the other 5 datasets are publicly available lesion segmentation datasets, which were never seen during training. And now we benchmark all the promptable models I showed in the beginning, so Meta's SAM model and all the other models, as well as our lesion locator. And this is our initial result. So don't be overwhelmed by the table. Basically, what you see here is that in green, you have better values, and basically yellow, reddish is worse values, and you see the DICE score being calculated on that very data set. And the right one is the NSD, but focus on the first value, which is the DICE score. And I'm going to walk you through here. So the first finding is that, as we saw earlier and already suspected, 2D models perform way worse than 3D models because they work on a slice basis and also only really work with box prompts, but still didn't really catch the lesions at all, especially in some worst cases where you really have really, really low DICE scores. Then we benchmarked the SAM2 model, where we took this video approach, so to say, in a way that you walk through the slices, but then again, you take the z-axis of the 3D medical image as the time axis. That gives some good results, but still the 3D models can beat that because they actually have 3D spatial context they can work with. And the best 3D model is actually this universal lesion segmentation model. That's how it's called. And this is specifically, as the name suggests, designed for lesion segmentation. But even that model is still performing, interestingly, 5 DICE points worse than our model when prompted with point prompts, and about almost 10 DICE points worse when prompted with box prompts. And I mean, I'm showing you all these numbers and showing you how great the model performs and out of distribution lesion segmentation. That's nice. But what really convinced me, also during the analysis and development of the model, that this is a good model and can really change clinical practice is when you compare it to human inter-rater variability. So for those tumor entities where we could find human inter-rater variability, so different radiologists rating the same lesion, which also don't always agree, right? You can see that we are really close to the human performance here. And this is a very, very good sign. And I think this is also one of the big achievements of the paper. And now, I promised it in the beginning, right? We want to do tracking. So let's take this to 4D. Let's not only do 3D segmentation, but let's really look into tracking the lesions. So here you can actually finally see the full model architecture. So on the right side, we have our well-known segmentation module we already talked about. And on the left side, we see the tracking module. And what is happening here is, I call it prompt propagation module, is that the general idea is that you map the prompt from the baseline scan into the image space of the follow-up scan. And how we do that is basically image registration. Probably most of you know what that is if you're from the medical domain, but it's in the computer vision domain, sometimes also called calculating, let's say, an optical flow or a deformation field between those two images. So you have the baseline scan on the left side in green and the follow-up scan in orange here. And you prompt in the image space of the baseline scan. So you click on the lesion of the baseline scan. And then, but because you have the two images, you can calculate the location of a voxel in this image, where it would be mapped, so to say, if you calculate the optical flow, where the location of the voxel in this image would be mapped into the follow-up image. And this is exactly what we do. So we take the point prompt or the box prompt of the previous mask, and we warp it into the image space of the next image. And to do that, of course, you need a lot of data, and you need time series data, because you want to train it in a way that we train the segmentation and the tracking together. We actually need the two images and also the two time series lesion segmentation. But unfortunately, there's no data set out there which really was able to fulfill our needs. So that's why we did two things. First of all, we made our own data set using a synthetic data augmentation. So we basically took the big lesion data set we had before, which is single time point, and synthetically generated a second follow-up time point. And how this exactly works is, I think, a bit too complicated for this presentation now. It's in the paper. But the idea is that you have your baseline image, you have your annotation, and you take the tumor annotation and you change the volume of the tumor and you change the appearance by making it bigger, making it smaller, doing an anisotropic, so to say, deformation field just around the tumor. So it can grow on one side and shrink on the other. And then if you have that, the second step is that you change the whole image to simulate a different screening of the patient. So you rotate the image slightly and you move it a bit, you deform it, and you do some variations with the image intensity, so classic augmentation strategies. So in the end, you end up with images like you see here on the right side, where you have a baseline an image with an annotation and then a synthetic follow-up image you can train the model with. By the way, this is also all publicly available, so you can download this from the GitHub repo if you ever wanted to work with longitudinal data. The second thing is then we, of course, need to really evaluate our model properly. So we also annotated a real data set in-house, the DKFZ, with real patients which were processed here and which were also annotated, and I think 4 different time points. So then the basically contribution of the paper is that we train things together. So coming back to the architecture, you have the tracking and you have the segmentation. And what was previously done is that you would basically do this tracking part offline in a classical image registration setting. So you would have the two images and you would register them, so you would know where the point location goes, and then you would prompt a segmentation module or promptable segmentation module to get your final segmentation mask. But what we propose here is to do this jointly. So to train it in a way where the registration loss is trained together with the dice loss and or cross entropy loss for the segmentation. And the big advantage here is, if you think about it, that if one model does a mistake, so if the prompt propagation is not working perfectly, so let's say you prompt the lesion in the baseline scan and it somehow aligns with a lesion in the follow-up scan, but a bit on top of the lesion. Then the segmentation model learns, well, I was prompted at this location, but there's a lesion very close. So probably I should segment the lesion very close. But if you prompt just the promptable model on a wrong location, it's probably going to give you a wrong output. And this is also what we could show in the results. So before I show the results, quick introduction on the metrics here. We have the die score, which is, I guess, pretty clear. Then we have a center point matching at 25 millimeters. Imagine this just as an accuracy of how accurately we can match lesions. Then the die score of the lesions we matched and the mean Euclidean distance of the center point. So how close is the center point of the ground truth lesion to the center point of the matched lesion? And if we look at those results, basically what you see here in terms of the baseline models is all models which are either just tracking a point, as you see here, or these two models basically do tracking and segmentation separately. So the first finding, so to say, is that if you train segmentation and tracking jointly, you achieve already state of the art, which was super nice when we found that out. And the second finding was in this table. By the way, this is a 5-fold cross-validation on the real data, so no synthetic data here in the evaluation. But speaking of synthetic data, what we found out is that if we then, on top of that, incorporate our synthetic data, we again get a performance boost. So what we actually did is we pre-trained the model with synthetic data, fine-tuned on real data, and immediately got 2 dice points of improvement. And last but not least, what we could also show is that if you propagate the predicted mask instead of a prompt, then you really have a big advantage. So imagine our tracking model, right? This is not only able to basically map a point location from one image to another, but it gives you a whole deformation field. So what you can do is you prompt your initial model with a box prompt, for example, and you propagate the whole box. So not only that one point. So you already have some kind of shape prior. Whereas if you take this to the extreme, you could also first generate a segmentation mask on the first image and then propagate the whole segmentation. So let's say you have a very long, thin lesion, then you first generate the segmentation mask of this, maybe even look at it, refine it, and then you use this information, which is a lot of information, way more than just a point prompt, to prompt the next image. So you propagate the whole segmentation mask, and this gives, in the end, then the best results, as you can see here. And lastly, what this plot shows is that we have a very consistent tracking performance over time. So you see here in the baseline scan, if you prompt the melanoma lesions, so the ones we annotated here in the DKFZ with, I think, box prompts it was, but could be point prompts as well, you get already like a very high dice score distribution. But then this dice score distribution for the lesions you correctly match, remains over time. So the box plots basically here are all pretty high, and those box plots show the dice score of the matched lesions. And speaking of matched lesions, what the red line basically represents is the center point matching, so this accuracy I mentioned earlier. And here you can see that from the beginning on, we are quite accurate. So sometimes we mistake lesions, sometimes we make confusions, but all in all, we are quite accurate. And this kind of slowly degrades over time, which is, of course, expected. But as you can see, it doesn't really degrade too much, even if you reach like follow-up 3, as you can see here. And this is, of course, like, as I said, expected that this kind of decreases. Imagine you have 2 lesions right next to each other, and one disappears in the next scan. Then if you prompt to that lesion location, the model will most likely think, okay, now it's the second lesion, which is then the wrong choice. But on the other hand, there are also disappearing lesions in the model, and the model is trained with that. So technically, it should be able, and we also saw in our evaluations, that it is able to segment lesions, or to not segment lesions which vanished. Same with merging lesions, but these are, of course, the edge cases, so it gets complicated here. And with that, I want to conclude my talk. Basically, the key advancements I showed is that for the first time, we kind of come close to human level performance in lesion segmentation if we use box prompts. that's what we could show on those 6 held out lesion datasets, so public and private. And then we presented a model about unified segmentation and tracking. And last but not least, we also provide a synthetic longitudinal data generation and dataset, which is all publicly available. And with that, I think this is a first step into getting that meta SAM2 model into the 3D medical domain. And here you can see some QR codes which you might want to scan. So on the left side is the GitHub repo, and on the right side is, I think, yeah, some information about me and my research. And I actually do now see that I have like about 2 minutes left. And I guess I can already tell, and many of you might have heard that already, this project has kind of evolved into a follow-up project as well, where we not only focus on lesions, but also focus on many different other structures. We don't do tracking, but it's called nnInteractive. And for those of you who haven't heard about this, nnInteractive is basically not just taking the ability to give you point or box prompts, but also Scribbles and Lassos, which is basically a more refined box prompt. And I'm not going to talk about nnInteractive too much. You can look that up on the respective repos. But just here, a quick introduction how it is in action. Unfortunately, it can't do tracking yet. But basically, what you can see here is that you are able to segment any different structure, any structure you're interested in an image, in this case, the liver with a scribble prompt. Here, the stomach, again, with a scribble prompt. And if you did some mistakes, then you basically reprompt, and you can also place negative scribbles. And here you see some small overflow, which we can immediately remove with some negative scribbles. And again, as I said, box prompts work, point prompts work, and I guess here I'm placing a box prompt, which immediately works. The box prompt is placed in one plane, so in 2D, and it immediately works as a 3D segmentation. What you just saw as a scribble, as a lasso prompt, and with that, in about like 30 seconds, you immediately annotated a 3D volume. So this is also might be interesting to you, and also stuff you can check out. And with that, I'm now really done with my presentation. And thank you for your attention, and I'm happy to answer any questions.
Fantastic. So we do have 3 questions in the queue, but let's go ahead and take one before we jump over to Heather's presentation. So this was the first question that came in, and it was when you were reviewing your results slide. The question is, how is the box prompt information integrated into UNet?
So the box prompt, basically, as I mentioned earlier, is similarly to the point prompt, where you would have another channel which has the same dimension as your image, and you would do the channel, you would all place only zeros in the channel, but at the location of the box prompt, you would do ones. And this is similarly done in nnInteractive. This is basically the same thing, where we have a spatial prompt at the same location where the user placed the prompt, which is all ones, and the rest is zeros.